Do we have any apologies for absence?
Just got apologies from Abigail Harris, but Marie Davis is here representing her today. Thanks, Chair.
Thanks, yeah. Declarations of interest from people.
It's my usual declaration of interest, Chair,
yes.
as employee of the GMC.
Thank you. Any others? No, thank you.
We've just had a message from Rian, who's having problems logging into the meeting.
Oh yeah, I see that. Thanks. Yeah, thanks, Gary. Yeah. Right. Did anyone else have any troubles getting in with their link? It was Sarah did. Yeah. Okay. Well, hopefully she can get in a few minutes time. We'll start. We'll start with the minutes, and hopefully Rian can get connected. So we have the minutes of the meeting on the 17th of May. I'll go through the each page of the minutes. We're looking at accuracy. If anybody has any accuracy issues, or if there's issues arising which are not otherwise covered off, please indicate. So first page, second page of the minutes, page 3. So it's I think it's 16 pages in there. So page 3 of 16, page 4 of 16, 5 of 16, page 6 of 16, page 7, page 8, page 9, page 10, page 11. Just on page 11, there's the item on sustainability action plan update. They were saying it's taken a while to recruit a project lead. That individual will start next month, which I guess is last month. So just that happened. Yeah, that was all okay. Then page. So that was page 11, page 12, page 13, page 15, and finally page 16 of 16. Okay, so I assume we're all content that those are fair and accurate and detailed minutes. Thank you. So we ratify those. Then we have the action log to look at. A number of items are completed. Actions in progress. There's one which says that's the key operational performance indicators. I think that might be discussed anyway during today's meeting, but it says in progress, date requested from Abby. Is that in? Are we going to pick? Is that going to be mentioned in later on in the meeting at all, or is that something that's needs to be nailed down?
I think, Chair, that's something that needs to be nailed down. I think we should put a date down for that for the September committee anyway. And then if Abby hasn't, if that piece of work hasn't been completed by then, we can move it to the November committee. But I think we should have a date in there, irrespective of, whether it's nailed down or not. We could always put a date in for the next committee and then always move it if we need to, because otherwise it will just there's potential for things to drift. So I'll make sure that happens, Chair.
Thanks. Okay. Yeah. And I think everything else, unless I'm misreading anything, is going to be on agendas going forward or has been completed. Is that right? So what the Mental Capacity Act monitoring report, we're going to have a verbal update today, it says here, from Mariel. That was the only other one I kind of queried. Yeah, Rachel, yeah.
So just for accuracy, under the one around the well-being, it has my name and then in brackets Rachel Wiles. It should say Claire Wiles.
Yeah, okay, I see that. Yeah.
Thanks.
Okay.
Thanks, Rachel. We'll pick that up.
Yeah. Okay, anything else? Okay, so that action log, subject to those couple of points there about laying down a date on the one and accuracy on the other. Subject to those, that action log is approved. Next is chair's actions. There have been no chair's actions. And then we move on to so that's standing items 1 there. Secondly, standing items items for review and assurance 2.1, shaping our future well-being strategy. So Abby is not with us today. On item 2.1, do we have a paper on 2.1 or are we going straight to 2.1.1? My question.
I think, Chair, that we're going straight to
Yeah.
2.1. I think 2.1 is the
just the heading,
overarching
yeah.
heading.
Yeah. I thought so. Just want to clarify. Yeah. Okay. So who's going to talk to our updates flash reports?
That'll be me, Michael.
Yeah.
Marie.
Yeah.
Yes. Sorry, embodied head. I'm still waiting for my super fast broadband to be installed, but it's a long and painful tale, so I won't bore you with it this morning. So you've had the papers from the 4 strategic programmes, and there are some additional flash reports in there as well, as we take an overarching view of our UHB programme portfolio when we meet monthly to look at progress. So you will have some flash reports included in this pack that probably we won't include because they're reported separately under different heads. So the recovery update and the workforce update will be dealt with by executive colleagues on their items of the agenda. But for the purposes of our reporting, we always make sure that we look at them as a whole portfolio to make sure that we are managing interfaces and interdependencies between the strategic programs and those programs that are being managed and delivered within ops. So I won't dwell on any of those flash reports because they are going to be picked up later on this morning by Caroline and by Rachel. But what I just wanted to say is that we've got the 4 strategic programs. So we've got Shaping Our Future Population Health, Shaping Our Future Services in the Community at Home, Shaping Our Future Clinical Services, which is our clinical strategy programme, redesigning our clinical services, and then Shaping Our Future Hospitals. So I've just lost my papers. That's excellent. So you will have received an overarching cover paper and a series of flash reports that underpin it. I'm not proposing to go through all of those, but I would be, of course, very happy to take questions on progress against any of those. So it's particularly the strategic portfolio. So slides 2 to 6 essentially are the ones that are reports back from those 4 strategic programs. So if has any specific questions on any, I would be happy to take them. There's a lot of information in there. It's probably also worth noting that we are working to develop our outcomes framework reporting. So we're working with David Thomas and colleagues and ops colleagues to try and develop a much more integrated approach to reporting, which includes flash reports, because I think it's important that you are able to scrutinise the activities and actions that are being undertaken to deliver service change. But we're also trying to look at a more visual means of reporting against key milestones. So whilst I think flash reports are useful up to a point, we also need to ensure that we are monitoring delivery against some outcomes. Our outcomes framework. So that's by way of kind of introduction and an overview. If there are any specific questions on any of the progress of the 4 strategic programs, I'd be happy to take them.
Okay, yes, Gary, yeah.
Thank you, Chair. And Marie, thank you. Just to reiterate, these flash reports are really very helpful. It's an extremely effective way of communicating a lot of information. I like them very much. I've got one specific question on the Shaping Our Future Hospitals programme. There was a very significant date yesterday. Have we got any update on progress following the Cabinet meeting discussion, if indeed it happened?
Sorry, I think I just dipped out then. I haven't had a report back at this point, so I don't know if it's good news or bad news or further kick into the long grass. But as soon as I find out, I will make sure colleagues are informed.
Okay, thank you.
Chair, can I just chip in here? Gary, I think the Cabinet meeting is today. I think it's scheduled for the 12th.
Yes, you're right. Yeah, it is.
July.
It's today.
So we might hear something later today, Gary.
Okay, it's just dated 11th of July.
Yeah, you're right. Yeah.
Yep.
Okay, yeah. Sarah.
Yes, thank you very much. I just had a specific question around shaping our future community services, which obviously is pretty fundamental. And one of the risks here is buy-in from GPs and service leads. Obviously, you know, the program's on red in terms of moving into the delivery phase, and I wonder whether you could tell us something about how that's progressing and what the effects may be of, you know, staffing gaps, people being, you know, having to continue to. I mean, there's a lot of COVID around again, isn't there? I mean, where are we on that engagement and the kind of the capacity and the ability of that sector to work with us, please?
So you've hit on a number of things there in that question, Sarah. We obviously, from an operational perspective, are back under the cosh quite significantly at the moment, and I'm sure Rachel will talk about that a bit later. And so all of the resources currently are pretty much focused on staying afloat and keeping the flow going through the community services, primary care, and in and out of secondary care. So we are struggling to get, you know, just the project team meetings fully populated at the moment because people are ill, and of course we're going into holiday season, which makes it a little bit tricky. Longer term, I think the biggest risk is providing protected time, in particular for GPs and clinical colleagues, to input into what is a huge programme of transformation. So if you look at the individual projects within the RPD portfolio, we're asking an awful lot of people, you know, in terms of giving up their protected time. So we are trying to make sure that we've got real clear focus so that we are picking off those areas which are the most important. So that's focusing now on the accelerated cluster development and trying to scale up and roll out where we've you know, developed good models. So that is a key focus. We've also got quite a lot of infrastructure work to do in the community, both digital and physical. And one of the key risks there is being able to put support in to manage the interface between operational and clinical colleagues and project teams to basically to develop clinical briefs and project plans. And again, that's a technical resource that often we struggle to recruit to or even fund. So that's a conversation at the moment we're having with RPB colleagues around some of the regional integration fund monies to see if we can work collaboratively to develop some joint posts using that funding to try and manage that planning capacity risk. So we're not out of the woods, but we do have a number of mitigating plans in place. But at the moment, I would say it's the operational pressures and the protected clinical time that we're really struggling to deal with.
Okay, Rachel.
Just to add to that, Sarah, we're actually doing a lot of work now with the local authorities around workforce and how we can sort of do a hybrid model. So my sort of assistant director is in conversation, so that seems to be progressing better and well, actually. And actually, I was out with, I went to Bryn Derwyn and to West Key GPs. There's a common theme there. I think there's still a lot for us to do regarding language and communication with our GPs, because I think there's a big hole that some of our communication, not necessarily with this programme that Marie just alluded to, but they still feel quite isolated and still feel there's a massive drop in the communication. So I think there's still a lot of work that we need to do there. Thanks.
Thank you.
Okay.
That's really, really helpful. And right.
Yeah, Jan?
Thanks, Michael. Marie, I just want to pick up on shaping our future community services, if I may. And in amongst the fabulous information that's in there, I can see reference to the Vale Alliance, but we're not referencing accelerated cluster development, and in particular the pan-cluster development planning groups. I know we've
Yes.
got one for the Vale. We're not mentioning the Cardiff side. So
Yeah,
can that...
so yeah, we can make sure that we formally update on that. So we are, obviously that is continuing to develop at pace, as you'll know from the recent board presentation. So yeah, this isn't an April update, as it says on the top of the thing, but it is probably a little bit out of date now, because there has been some really good development around accelerate the pan cluster planning groups. Lisa and Kath are all over that, so that's actually genuinely pretty good news, I think. The other point I was going to make on the sort of risks around capacity to deliver is really around engagement. When you list all of the individual projects that sit within these programs, there are tens of them. So you're talking 10, 20, 30 individual projects that are trying to be coordinated under these program headings. And one of the things that we are concerned we need to do better, and in a more coordinated, organised way, making sure that we are using all of the resources that we currently have deployed across the organisation, is around a more structured approach to engagement and communication. So Joe and I have now established a formal strategic comms and engagement group to sit underneath these programmes, to make sure that we aren't duplicating, we aren't missing opportunities and responsibilities to engage, that we are, and we've got the CHC obviously on that group as well. So we're trying to pull together a much more coherent and integrated comms and engagement plan that underpins our strategy refresh and our strategic programmes. And I suppose what it's highlighted is that there's more that we should be doing, and in terms of meeting our duties, probably. So we're looking at ways that we can do that with the resources that we've got, and if we are able to secure resources from other sources, what we would do with that in order to try and ensure that we are engaging effectively and appropriately in line with our duty.
Okay, thanks. First of all, Jan, do you want to come back on something then? I think is that.
Yeah, thanks, Michael. Apologies, Sarah, for pushing in front of you. Didn't mean to. On that engagement piece, Marie, it's really important for us because we're starting to get some pressure from a few elected members locally about how we engage.
Yeah, I know.
And we've learned perhaps from our experience with the Barry situation how not to do it. And really, we must be engaging with our population before we develop our plan, rather than present them with the plan and then ask them to engage on it. So it's trying to switch that emphasis around. So I'm delighted to hear that we're paying a lot more attention to the engagement side. Thanks, Michael.
I completely agree, Jan. I think the particular issue that you're referring to, those plans actually weren't our plans. They were someone else's plans that were given to us. They said, "Isn't this a great idea?" But you're right. You know, we need to do engagement in a timely way, and that's really tricky because, you know, it's important that we engage our wider stakeholder groups as we develop options, but sometimes that has the effect of raising expectations that we're about to secure a big chunk of money to take a scheme forward, and then we get to that point and we find, you know, there isn't the opportunity to do that. The issue for us is one around resourcing. We only get, so for big capital schemes, for example, like North Cardiff Health and Wellbeing Centre, we will have to secure resources from Welsh Government in order to progress that scheme further. And that will be a big capital commitment. And we can't really work that up until we've got those resources in place, at which point then we can start to do much more explicit engagement. So if we start to do that now, and then we and through our capital programme at the moment, we have got that scheme as not a priority scheme to take forward this year because of the capital situation. So again, it's just creating the right balance of keeping conversations going, maintaining a level of continuous communication, but making sure that we don't go into formal engagement until we've got a plan, you know, a clear plan to proceed. Nick, you're right, it should be an ongoing dialogue. And so we do have established now the I think it's called continuous engagement group with the CHC, where we do make sure that our CHC colleagues are clear about where we are in terms of planning and delivery on some of our big capital and service priorities. And we also provide them, I say we, it's not me, it's Adam Wright provides them also monthly with a service tracker of all of the service changes that have and are taking place within operational services, to make sure that there's clear and transparent understanding about what changes are taking place within our services.
Okay, thanks, Mary. Can I have one more question on just this is a flash report a minute from Sarah?
Okay, so I'll move on a little bit to some of the performance reporting as well, because the point covers both. I mean, it is external engagement, but it's also engagement and leadership with our own clinical staff, because I think, you know, it's important that there's a feeling of ownership and agency from those staff, and it's very linked into all sorts of things that Rachel is going to tell us later on, I'm very sure. Just a kind of a reflection, obviously this plan was put together BC before COVID, and just looking at the interplay between the rest of this report, do we need to have a look at this programme and say, is it still feasible to have this breadth of change, or is there a focus, or is there a sequencing? You know, honestly, where do we think we are? It's just a question, and obviously it's a big question, but just putting it there.
Do you mean across the whole of the strategic portfolio?
I do.
Yeah, no, I think, and I think that is an absolutely legitimate question. I think if you look underneath each of these programme headings, at what we are trying to achieve, it is vast, and therefore we need to be clear. I mean, and particularly if we get a green or even an amber light from Cabinet around shaping our future hospitals, that's a signal of really having to lift our game in terms of our clinical service redesign planning, for example. So at the moment, we've just done 2 service lines as part of our clinical redesign planning. If we do get a green light from Cabinet today, then we are going to have to look at how we lift that piece of work and accelerate it. And again, given some of the risks that are articulated in those flash reports, it does mean that we're going to have to slow down on some other things potentially. I think as our strategy refresh progresses over the next few months, I think that will help to give some shape and focus on priorities underneath these strategic headings. So and you may see some projects merge potentially as well, I think, which again might make it from a program management point of view, it might be a bit less unwieldy. So it's a good question, and I think it is something that we will need to review and take stock of as we are going through our strategy update process. Sarah.
Right, okay, thank you. Right, so first of all, there's something I just want to make sure I'm following correctly here before we kind of sign off on something. We got two things we got to look at: the integrated medium-term plan update
Q1.
Yeah. And there's also the background context and baseline information booklet.
Yeah.
Do we look at those together or
yeah, we do look at them together. And
okay, well, hold on, I'll come to that in a second then. Okay, right. So should we just note that we noted the progress and risks in the flash reports? Should we just make the committee notes and just discussed them? Okay, so I want to keep that like separate. And then we go on. Then there's a very short background paper about these about the integrated medium-term plan update and the background paper. But can you just tell me what is the relationship between the background paper and the the Q1 update? Yeah. And treat me as if I'm like a 5-year-old child and tell me how that works. Yeah.
That's no problem at all. I have had children. I can do that. So just to let you know that this is work in progress, this report. So it's a bit it's not an easy read, I have to say. So we are working quite hard at the moment to try and develop this so it is a much easier read. So this is due to come to board formally in July, which is the Q1 update, which we will then send into Welsh Government. And this is our kind of very first draft, and we've already done quite a lot of work to tidy it up and make it an easier read. So the content is pretty much the same, but the presentation is much easier to follow, because I think this one is a bit hard work, if I'm honest. But the principles are absolutely sound. So what we've done is produced a document which is described here as the baseline document, and that essentially is a summary of the key priorities in the IMTP. So if you look at slide or page 59 of 183, it is on my screen. So from 59 to go all the way to 183, probably. No, from 59 to 76. Those slides are the key IMTP deliverables under the IMTP heading. So those were the things that we said underneath our IMTP priorities. Those were the key deliverables that we articulated we would be delivering against, and where there are measures, we've included the measures. So we have got 7 priorities articulated in the plan, under which we have got a number of key milestones and deliverables. So that is your baseline document. That says this is what we've said we would do in our IMTP, and it is against these key deliverables under those priorities. This is how we're doing at the end of Q1. So that's the first part of the document then, is what we said we'd do and where we are. So if you go back to the top then and look at the Q1 update report, ignore the dashboard for now, because that's our outcomes framework that we're developing. So ultimately that slide 42, which shows the outcomes framework, that will be populated throughout this year so that we can start to link key milestones into that dashboard and give us a heat map of where we are in terms of delivery. So you can see the red, amber, green there. We will populate that, so at a glance you can see where we are in terms of delivering against our key outcomes as articulated in our outcomes framework. But that's work in progress at the moment, as we are trying to link up all of the schemes. And then the rest of the report basically says, under each of the priorities, where we said we would be, what's taken place in Q1, and where we're going to be for the next quarter, so that we've got something to monitor against then at the next quarter. So as I say, this is work in progress. It will already look a lot tidier when it comes to board and goes into the public domain, because we think this one's actually a bit scrappy still. And what we wanted to do was use the opportunity of bringing it to you today in its rough and ready format, to get your feedback on how you would like to see this developed. Bearing in mind that I might not be able to turn it around in 24 hours for this board or next month's board, this month's board, but we would really welcome your feedback on this so that we can get it right. I can see Jan's got his hand up, Michael.
Yes, thank you. Yes, well, thanks for that. Yes, Jan.
Thanks, Michael, and thanks, Marie, because I actually didn't think this was particularly scrappy, to use your words, at all. I thought it was a very comprehensive update, which I think the board will benefit from greatly in terms of how we're monitoring our performance against the IMTP.
Okay.
I appreciate you're going to refine it, Maria, and that's fine. I think that would help further, probably. But it does need to be fairly comprehensive for the board to have a good idea of the progress we're making. My nervousness, again, is around the outcomes and the development of the outcomes.
Yeah.
We continue to be criticised from Audit Wales, for instance, and I know that independent members are equally concerned about our need to have clear milestones and monitoring delivery against those milestones, so we know whether we're on track, off track, and if we're off track, what we're doing about it. So can you give assurance to the committee, Marie, that this development of outcomes will not be protracted, as it seems to have been over the years?
Yeah, no, we've got a good little group working on it now, actually, Jan. So I think we've got all the right people in. So we've got David Thomas, we've got I&I colleagues, we've got Change Hub colleagues, we've got planning and ops leads. So I think actually we've got all the right people around the table to actually try and join this up more coherently. And what we want to try and do is the Holy Grail, which is have a really integrated approach to performance reporting and assurance, both short, medium and longer term, and we can use the outcomes framework at a number of levels, and that's what we're aiming to do. So I would certainly hope that, in the next quarter we would have something really, really quite meaty to bring to you. So the outcomes framework is something we're really keen to ensure is utilised, and we will want to also link, obviously, the new performance framework metrics that have just been issued by Welsh Government. We would want to, where we can, make sure that they're all linked in underneath this as well.
Thanks, Jan. Rian, I think I can see. And
yeah, diolch, Michael. Thank you. Marie, I think this is great. I'm genuinely encouraged by it. I think, I've been
Can I just interrupt and say, I didn't do this. John Watts did this with Adam.
Fantastic.
And they worked, because extracting information from very busy operational colleagues is an absolute flipping nightmare.
I can imagine.
Adam and John did that. I'm just presenting it.
No, that's a very fair point, and credit to them, because I think one of the things I've gone on quite a bit about since joining the board is, the fact that I feel sometimes reasonably uncomfortable that we're not keeping on top of, progression, performance management, etc. So I think this is a fantastic start. I'll just reiterate what I said in the comments in terms of I really like the approach. This is what we said we would do, this is what we've actually done, and targets for next quarter. What I would say is that it's very hard to jump from one column to the other and not lose track of where you are. So if there's a clear linkage between bullet point 1 and then next bullet point 2, even if it's a meaty bullet point describing what's actually happened, I think it would help with tracking progression.
Yes.
Another point is, obviously this is on a quarter by quarter basis, so we could use this to reflect on annual performance, just collect all the quarters worth of data and reflect annually. What I'm nervous about, again, in terms of formatting, is that if we have some issues that go beyond a quarter because of delays or, lead times, etc., are we going to be clutching up the first column potentially, or the second column by I just think some thought needs to be made on stuff that take beyond a quarter, or we break down our milestones a little bit more in detail, you know. But I just wanted to just say fantastic. I think this is a really great start. I think it will truly help us as board members to reflect on, well, one, to remind us of what we said we were going to do, but also to reflect on where we actually are, and to be able to identify risks before they sort of, not just before they arise, but before they get into bigger risk territory as well. So thank you. Diolch.
Thank you.
Okay, thanks. Just appreciate that we're talking about, you know, the early beginnings of this update report. I echo what Rian says. It's very helpful. I think I'm making the similar point to Rian, but maybe in a slightly different way. Is that if you look at the first column about what we said we would do, and then read across, there's loads more information in the next column normally about what actually been undertaken. So actually, it's not easy to kind of read across and say, well, did your increased activity in dental services did that? So I think it needs to be kind of slightly easier read across, but then but I think it's getting there. There's a bit of repetition in some bits as well. There's the same thing pops up a couple of times. I like the major risks bit. That's nice. Even I can understand that. That's quite nice and easy. And I think also just be aware that when you're using kind of an acronyms and things, initials, that some of us are not, you know, so embedded in day to day that it's handy to make sure there's always a little thing saying what that means fully. Absolutely. Just be aware of that, because that happens in some bits, but some bits it doesn't. So that's only my comments, but I think a good step forward. Well done. Yeah.
That's really helpful. Thank you for those comments. I'll take those back to the team and make sure that we probably won't get it in for this month's board, but we'll certainly take account of that when we do the Q2 update.
Right. Thanks. Great. Okay.
Thank you.
Yeah. So I say a work in progress, but a good start. So we're requested to note the I think we're noting that. I think notes the progress and the and our comments will be noted. Our feedback will be taken forward on that. So I think that is. Just lost my agenda a second. So does that deal with 2.1.1? Yeah. So on to performance reports themselves then. So is that I think Rachel's leading off with workforce on that, I believe.
Yeah, great. Thanks, Michael. Yeah, so as normal, we have two papers relating to the workforce KPIs. We've got the graphs and we've also got the narrative to support that. Just as you're aware, when we publish the papers, there's actually a sort of dated. So I've just got some information, which is our June KPI. So I will bring that into the narrative. With our sort of key areas that we talk about, that our concerns are turnover rate within our workforce, and that is slightly reducing in our June KPIs to 13.5%, still remaining high, because a sort of a healthy turnover rate, we aim for around 9%. So we're sort of digging deeper actually as a team to look at not only turnover rate, but how that triangulates with other data such as sickness, but also we're launching some engagement tools. So again, how can we support those areas and really find out what's happening? Our sickness, as you can see, accumulative, but also what it is for the month of June now is just over 6%. So it is coming down again, but there are areas still showing quite high rates of sickness. Nursing and midwifery, which Jason may want to comment on, but that's just under 7%. But there's specific areas in capital estates and facilities. And when I looked at the detail, there's quite a lot around our facility staff, portering and catering. Again, we're having discussions around how can we ensure, or going forward, look at them being part of a ward, an establishment, so they feel that they belong into an area. So again, we're currently just talking around how that might be. And our allied health actually are showing just over 10% turnover rate. So We are, as you know, with the People and Culture Plan, there's key objectives and milestones related to that, and team leads linked in with trade unions, colleagues. So not only trying to get being present out and talking to staff, but really looking at the data to inform us. Some key areas for me that I'm still concerned around the low levels is our value-based appraisals, and we can't keep saying it's because of COVID, because colleagues in other health boards and trusts have higher levels of VBAs. So I know the team are streamlining the document because it's quite a healthy document, and you've heard me say at board recently that it is the right approach, a value-based approach. But I think talking to some lead nurses recently, they felt that it was just very heavy when they've got a big team to go through each appraisal. And again, the addition of putting on ESR. So I've asked the team around how can we make it streamline a few bullet points to help people put the date on, because the date's really important, especially this year within our pay progression. There are a couple of hundred of individuals that will go through their pay progression, but it was delayed through COVID, but there will be unless they have a VBA documented on their ESR, they will not go through their gateway and get their pay increment. So we've been doing a lot of communication around those areas and with the managers, probably more than we would do usually, but we realise that the support is required out there. Again, you may see and I know in private sector I'll go into more detail around employee relation cases. That has decreased over the years. What I would say that although there's about 19-20 sort of showing in that employee relation cases, we do have just under 70 in the organisation, but because of the just culture principles and the fact finding, we're able to close those down very quickly. So those are the ones that are formally going through. And then just as you can see, there's some proactive work around how we recruit, whole system approach. I'm actually off to a career fair on Saturday to our Somalian communities to talk about opportunities. And I know Jason's unable to join this time, but his deputy is coming as well alongside the resourcing team. And then some intervention around engagement with Swartz rounds, which is a debrief for a whole organisation approach to learn and around different interventions such as the inner wellness sessions, which are coming out tomorrow for all staff about inclusive inner wellness, that we were able to have an outside speaker to do 3 months hour series, which seemed to be going down well, the 1 hour sessions. That's the feedback. People are able just to access those rather than whole day study days. There's a lot of information, so I think I'll pause now and just allow for questions. Thank you.
Thank you, Rachel. Can I just say, if there's, we are going to look at the paper later on health and safety culture plan. So people who've got kind of general high level points which might touch in that, can you try and save your fire? But is there anything particular on figures and anything particular on performance, then please fire away. So I think Rian has a hand up. Yeah.
Yes, please. Diolch. Bore da, Rachel. Just a really quick one. It's around your section on people resourcing and how we've had X number of applications and Y number of candidates successfully appointed. It seems to be a really high success rate. 130 applications and 99 candidates successfully appointed. 130 facilities applications and 80 have been appointed. It doesn't seem like we have a lot of applications coming in versus the posts being appointed. It is a really high success rate, if that makes sense. Is that a reflection of the fact that we're getting really high caliber applicants, or are we seeing some progress in terms of successful tracking and identification of potential applicants that we are encouraging to apply?
Yeah, a little bit of both, actually. So I think this success came from when we went into the community. We actually went into the centre of Cardiff, and we were actually proactively interviewing and recruiting on the day. So I think that gave some pace around it. I think having a resourcing team for the organisation, they can really look at being proactive around getting out to, I know they went to a military fair recently to look at ex-military staff in Bristol. So they're actually proactively going out there. I think it's really important. The candidates seem to be out there. We need to be doing more of that. What I'm going to be doing, and I haven't alluded to this actually, Jan mentioned it at board about workforce being a monthly performance review with the clinical boards, which we are now going to be doing. But what I'm noticing in the organisation, there's some creep around agency for healthcare support workers, and there's no need to do that. I think with our proactiveness, we can recruit. So I think it seems to be there are the people out there in the community. It's just about us being proactive and doing it at pace, really, to get people into jobs.
Understood. And will we be sort of proactively tracking the retention rate of these new cohorts that we've maybe changed tact, changed our methodology, etc., to attract and recruit? Will we be looking at, the longer term impact of that at all?
Yeah, absolutely. And we were talking about vascular yesterday, actually, and some of the successes that we've had with our nurses. And I was saying that it's important to make sure that they are retained. So there's so many different with the people and culture plan. There's not just one theme; they all actually interlink. So for definite, we'll be. I mean, for me, Rian, it's the people who didn't get the jobs. I think we need to do more work with. I think it's about signposting to employability skills. Why did they not get the jobs, and giving them the proactive feedback, but asking them to come back if it is to do with some upskilling. I think that's our duty for our economy. So I think there's more work around the people that we don't employ, actually.
Yeah, really good point. Diolch, Rachel. That's helpful.
Thank you.
Okay, any other questions on that? No, thank you. Well, thank you, Rachel, on that. I think that will then take us to Caroline. Caroline, and I think you're going to do a couple of presentations for us, Caroline, isn't it? First of all, sorry, we need to make the note that we note and discuss the contents of Rachel's report. Let's make sure we note that for the record. Sorry. Okay. Now then, so presentation then, Caroline. Yes, on 6 goals for urgent and emergency care is the first one, I think. Yes.
It is, Michael. So I mean, there's also the usual performance report on the agenda, but in reality, I wasn't going to go through that in detail, Michael, because of the 2 presentations that we've got. The first presentation, as you say, is around 6 goals for urgent and emergency care, which I'll take you through, and Hannah Evans is here to take you through a second presentation then on planned care. And the position and the plans in that arena. I think probably just before I do that, it just may be worth mentioning just a couple of other areas on the performance report. So for primary care, again, we have continued to have sort of system-wide pressures. We've mentioned COVID a couple of times, and so those pressures in primary care can continue as well. And sort of this week we've seen an increased number of practices at a higher level of escalation, so at 12. Dental, again, is a big priority for us as a health board and also a ministerial priority. I'll pick that up under the urgent and emergency care, the 6 goals presentation, because that forms part of that. So you'll see our improving trajectory there. And I did want to just touch on mental health. Because again, I mean, there's been a significant impact, as we all know, due to COVID, and their wave is still, in some ways, being felt, I think, actually. So in terms of that increased demand, the increased acuity, and then particularly around the inpatient sort of presentations as well. I think in the performance report, Michael, you'll note the Part 1A improvement for adults in particular. And we'll see, I think, in future performance reports that adults is now compliant, which is really good news in terms of the teams. We are, however, now having a few more challenges in CAMS, particularly around the workforce constraints. So So we're seeing a dip in the headline performance. But again, it's important to know, I think we always look behind that headline performance and look at average waiting times, etc. Now that hasn't gone out too much. So our current average waiting time is 25 days, and we have plans in place now to address some of the workforce constraints that we've seen within CAMS, and some of that has been short-term sicknesses again, but some of it is longer term. So we do have plans in place. So I'll pause there. Happy to take any questions on other areas, but if not, I will, if you bear me a second, I will just share the presentation.
Yes, sorry, Karen. What I meant to say to people was that I didn't want us to go into the operational reports because a lot of some things might be covered in what you're going to say now. But I mean, if people had any particular issues, maybe in mental health or something, which, as Caroline said, is probably not necessarily going to be covered off in what she's going to say now, then feel free to raise that. But I suggest that we let Caroline do her presentations first, because I think this is quite important to see this kind of high level strategy which to inform us, and then we'll pick up questions arising out of that. And if people want to cross refer back to the if I call it the clinical operational reports, then that would be the right time to do it. So if you kind of inform us with the those first, Caroline, then we can pick up issues after that. Okay, thank you.
Okay, lovely. All right, thanks. So I'll start then, Michael, then with the 6 goals for urgent emergency care. And what I just want to do is just sort of give you an overview of the national context, because this is the first time this has come to this committee, and then also just outline some of the work that we're doing locally, partly related to the 6 goals, but just give you a flavour as well of some of the other work that we're trying to do to improve the urgent and emergency care position. So just sort of start off then with the context. So the policy handbook for 6 goals was published in February 2022, but the actual sort of launch, if you like, of the concept was in 2021. So it spans a 5-year period. So you'll see there from 2021 through to 2026. So it's not just about short-term actions. This is more about how we get a sustainable urgent and emergency care system. It's supported by £25 million worth of funding across Wales, of which our share at this current time is nearly 3 million, £2.960 million. The policy, I've put the narrative there in terms of if people want to actually read the policy document. There's 2 actually. There is a more detailed policy document, which is that link there, but there is also for the public an easy read, which is probably worth noting. I mean, the handbook itself sets sort of system-wide expectations. So this isn't just about health. This is about health, social care, the independent sector and the third sector, and how we work together to deliver the care within the urgent and emergency care sort of space. The 6 goals, you will see the diagram here on the left-hand side. I mean, I won't read them all out for you, but it basically covers all of the pathways. So from out of hospital to in hospital, discharge from hospital, and then sort of care in the community. And then the policy handbook, I thought it's probably worth noting, the policy handbook describes a number of immediate priorities. So whilst this is, as I said, actually the policy direction, up to 2026, there are some more immediate priorities described within the handbook. And if you just have a look at the right-hand side, I've tried to sort of pull some of those out. So, for instance, in Goal 1, you've got the accelerated primary care cluster development, and again, we had that sort of presentation at board development around some of that. There's the ambulance handover improvements. You'll see that in Goal 4, and then Goals 5 and 6 are very much about working with our partners on how to improve discharge. I think it's probably worth noting the reason why the yellow stars are there is that Welsh Government focus and the funding that they've given us, so that 3 million that I've discussed, really focuses on this year on goals 2 and 3, so around the urgent primary care centre and extending same-day emergency care. So that is very much the sort of national focus in terms of that one. I suppose it's just important then to note, I mean, that's sort of the policy, the priorities, etc. What I just wanted to do then was just outline that how the 6 goals are then starting to be reflected in sort of current performance measures. We've had a new performance framework issued by Welsh Government in the last couple of weeks, so this has been updated. So a lot of the measures are the usual measures that we look at within the committee. So for instance, the sort of 4-hour number 25 there on the left hand side, the sort of 4-hour A&E target, the 12-hour wait target, etc. But you'll also start to see now some new measures being introduced. So for instance, linked to the 6 goals, at the top there, the number 17, the urgent primary care centres is now a measure. And again there, number 23, you'll see there about same-day emergency care. So I think that performance framework has started to evolve with Welsh Government. And again, we'll start to reflect the different performance measures now, both in our reports to this committee and also then going forward, obviously, to board in the integrated performance report. And then I just sort of wanted to take you through a little bit more detail, I suppose, in terms of our approach and some of the schemes that we are moving forward with. So, I mean, our approach to improving urgent and emergency care to date has been taken forward via 3 interrelated plans, and I think I've relayed this to the committee and also to board in the last sort of couple of meetings. And the 6 goal plan, which is on the left hand side, the system plan, if you like, actually is a key part of our overall approach, but it isn't the only approach in terms of improving the position. The other 2, as you'll see, so there's the sort of 6 goal plan, which is the 6th plan, but the other 2 specific plans that we've been taken forward are the ambulance handover improvement plan, and that is a joint plan that we've developed with Welsh Ambulance Service in terms of how we can actions that we can take forward to, as I said, improve ambulance handover. So you'll see things in there like strengthened escalation at the front door, how we can avoid conveyance, which also does link into some of the schemes around the 6 goals, and again a different sort of admitting pathway so that the ambulance conveyances don't necessarily have to go to ED and go to the right place sort of first time. And then the sort of 3rd plan we always sort of call the immediate action plan, and in reality this is our operational action plan. So, you know, on a weekly basis, you know, we look at how the system, if you like, actually is operating, and in response to the sort of the different pressures, I guess, that we have, we agree sets of actions within operations that we need to take forward. So you'll see a couple of those. I think I've talked before about one of them was about reconfiguring the EU footprint, which has now been completed to improve flow within there. We noted an increase in terms of number of attendances to our ED department, which we felt could be managed elsewhere. So we put CAV 24/7 at the front door for an 8-week period, and that'll shortly be coming to an end. So we'll be able to sort of review the impact of that to support redirecting patients, and again making sure that they are seen in the right place. So those 3 plans, as I said, are interlinked, but just a little bit of a focus, I suppose, for you now on the system plan. And in particular, I just wanted to pick up the governance, because I'll come on to now a second some of the details within that system plan. So I think it's probably worth the committee noting that in governance we are setting up a system-wide integrated transformational board for the 6 goals in urgent emergency care. There are draft terms of reference. We've agreed that will be executive led, so that will be chief exec, and that will be jointly chaired between health and local authority, recognising actually that we are one part in a system-wide and we need to work with our partners to on schemes to transform that. But in saying that, whilst that's been set up, that, as I said, draft terms of reference are in place, and our aim is now to get that up and running by September. We haven't been waiting for that to take forward a number of schemes. And you'll recall we were given funding last year in terms of recovery, and that's continued into this year. And we've taken a number of schemes forward via, if you like, it was recovery and redesign last year. This year it's through our sort of operational plan mechanism, and that has continued into this year. And we've got a delivery mechanism already in place for that through an urgent and emergency care operational delivery group, and then that feeds into a meeting. A wider operational plan delivery meeting, sort of chaired by the Chief Operating Officer. So I just wanted to outline that governance, and now and through the next few slides, I just sort of wanted to sort of take you through some of the a little bit more detail, I suppose, about some of the schemes that we're implementing. This one, I won't linger on this slide too long, but this is a visual of the work streams ongoing and how they fit into each of the goals. So you'll see the goals down the bottom. You'll see the sort of service areas by each of the sort of pillars, etc., and how they sort of all fit together. I suppose what this does show is that there is a vast amount of work ongoing to improve our position overall on a sustainable basis. And the red boxes, if you like, actually just highlight the priorities for us going forward. So I just wanted to pick up on a little bit more detail now on some of those priorities. So the first priority I just wanted to pick up on is in the primary care space, and this is twofold. Again, linking back to those original the 6 goals. So this slide, if you like, probably shows some of the work ongoing in terms of goals 1 and 2. The left-hand slide is relates to dental, so the top graph, and then the green box down the bottom specifically relates to dental, and I suppose the opportunity and constraints that we've got in terms of improving our access to urgent dental services and general dental services. The opportunities for us have been around new contract reform, changes in IP&C measures, and you can see on the top graph actually that we have got now an improving trajectory of GDS activity. So we were running around about the sort of 40% mark come April. You'll see now we're close to the 60% mark, and we're working with PKIC clinical board now on that improvement trajectory through to the quarters and through to the end of the year. And then the right-hand side, again, I won't go into this in detail because I'm conscious that you had a much more detailed presentation in board development, but the right-hand side in effect reflects some of the work ongoing in the accelerated cluster development and then the plan cluster planning. It's always a bit of a tongue twister, isn't it? Planning arena in terms of that one, and lots of work again going on as we've heard earlier in terms of the at home and the Shaping Our Future community services programme as well. And that's an important, if you like, actually bedrock really for us in terms of that system-wide working. And then just picking up on the 2, I suppose, priorities, again, which have been a focus nationally, and as I mentioned, that specifically a direction from Welsh Government in terms of where we were directing some of our £3 million worth of resources to. So the first is around the urgent primary care centres. Now, I mean, I'm sure most of you will be aware on you'll see there from the left-hand side, sort of pictorial there, our Vale model. The model for Vale has been running now for a while, and on average we see circa 2,500 appointments a month. That's certainly for us supporting GP sustainability, which is excellent and needed. But I think now, again, you'll see on the right-hand side, we've got some further work now to do, I think, on how we embed that model, how we increase the capacity, and in particular, I think for me, how we ensure actually that model works for the whole of the system. So GP as well as supporting, if you like, actually the front door within the hospital. You'll also be aware that we don't have a model currently in Cardiff, and certainly that is a gap in our provision. There is a national review. There's different models across Wales, so there's a national review currently of models, and we're expecting that feedback from that to come out hopefully by the end of this month. And we're going to use that national feedback plus our review of the Vale Urgent Primary Care Centre to inform the development of the Cardiff model. I think it's probably worth noting for the Cardiff model that any model will require or is likely to require investment, and that is not covered by the 3 million that we've received. So again, we need to work on how we definitely do need something in terms of Cardiff. So we'll need to work on what that model looks like and how we can fund it. And then just a final slide, really, on the same day emergency care. And I just wanted to highlight some of the excellent work that's been done within this space. I mean, that's a model of a care. I mean, apologies if if you're all already aware of this, but this is a model of a care basically where we rapidly assess patients, we diagnose them and treat them with on the same day. It is what it says on the tin. Within the sort of same day, and these basically would have been patients who otherwise would have been admitted into our beds. So this is a really, really important development for us. On the left-hand side, you'll see there we sort of split it into sort of surgery and medicine. We implemented a new same-day emergency care model in April 2022 for surgery, but it's been on a phased basis basically. So that was a limited capacity. It's been supported heavily by a big capital investment and a big revenue investment. And I would encourage people. I think once phase 2, I'll come on to that now, is up and running, and I would encourage people to go and see how that's working. I think it's an excellent model. It was developed with a great clinical leader actually in terms of that. So a really, really good model. And you'll see there we are further extending that now this month. We were hoping actually to go live yesterday, but there were a few snagging issues in terms of environment, etc. Because it has been a new build. That we're hoping those are going to be resolved now this week, and so that phase 2 will go live next week, and that will then provide, as you can see on the slide, a total of 24 trolleys, beds, and chairs, and they'll deliver a hot clinic, a sort of a hot clinic model through there. And then I think we have got then further opportunities in other spaces for this sort of type of model. We're trialling currently trauma same-day emergency care model, just a small test to change just to see whether what benefit that will give us. We're also looking actually about whether we can do something for diagnostics. So again, we've identified that we have patients actually waiting in our beds for certain diagnostics. So could we do that through again through a sort of similar type of model, and again you'll see there that we also think we've probably got opportunities in terms of gynae and paediatrics as well in particular. And then the other, I suppose, I was going to say biggie actually, is on the same day emergency care, and where we've got a big opportunity is in the medicine space. So again, most of you will be aware we've run our medical emergency ambulatory care unit for a number of years now, but that's only been running Monday to Friday. I suppose we've seen progress now in a couple of areas on that, with the support of the funding, with the support of Rachel's team in terms of recruitment, etc. Around two things. I think the first one is about implementing a virtual ward, and again, great clinical leadership within that space actually to take that forward. And I think then the second thing which we've done, we've now extended its opening hours so that it now opens on a weekend. But at this current time, it's only for 8 hours a day, and we're still having a few issues, I suppose, with resilience of staffing, particularly in light of the recent sort of COVID wave. So our plans now are around making sure that we're resilient in the first instance, that we can run that service 7 days a week for 8 hours a day, and then the next phase then, which we're hoping will be in place by October, subject to sort of expanding our workforce, is that will then open again 12 hours a day. And then we've got other opportunities again in all of those spaces. I talked earlier around looking for opportunities, I suppose, to redivert ambulance conveyances, so they don't necessarily always need to go through our EU department. And again, we're looking at implementing direct paramedic referrals into our same-day emergency care models. The only health board currently to have done that in Wales is Hywel Dda, but certainly I think once we get surgery phase 2 up and running next week, we'll be able to do that fairly quickly, I think, actually for surgery, and then we'll also then be looking to do that for medicine. So I'll stop there. Sorry, I appreciate that was probably quite a lot of detail for you, but I mean, hopefully that just gives you a I suppose a better understanding of the sort of national context and of the sort of 6 goals and of the sort of plan around that, and then hopefully it just gives you a flavour of some of the work that's ongoing within that space. Thank you, Michael. I'll take the slides now so I can see, but happy to answer any questions, or again, happy to go into the planned care presentation, depending on how you want to play it.
Right. Okay. Well, I'll let you take a breath a minute, Caroline. So, and then before that, so anybody got any points arising out of that presentation, which was very helpful? Jan.
Thanks, Michael, and thank you, Caroline, and your team for the great work you're doing. It really is encouraging to see the number of positive measures that you're taking to try and address the situation we're in. So thank you for that. And I'm not sure if anyone else has seen the slides. I certainly haven't before, but I'd welcome a copy of those, Caroline, because they do summarise not only what we've been doing, but what we trying to do going forward. If I could just narrow it down to the urgent primary care centres for a second and ask about the Cardiff side, which I know you'd rather have up and running sooner rather than later, as would I. It does seem to be quite a long lead-in period, 23-24. And funding, you highlighted the need for funding. Now, is there any available capital? Is there any way we could speed that process up? Because I think it's needed more in Cardiff than the Vale. And are we thinking about any potential locations yet, please?
Yeah, thanks, Jan.
My camera's off, Chair, because Nathan said we should put our cameras off to ease the burden. If you want me to switch it on, I'll happily do so.
Yes, thanks, Jan. I think it isn't just about a physical location. It'll also be about what model that we implement, because given some of the workforce challenges that we do have in terms of recruitment, I think we need to look at how we provide the urgent primary care model, if you like, across all of the clusters. So the opportunities for me are as I said, once we get the review about, you know, is the Vale model quite the right one, etc. Could we capitalise on that to expand it across to Cardiff sooner, as you've just said? Just in terms of the funding, this will require not just capital requirement, and there isn't capital at this current time. It'll also require revenue, so it'll be twofold. So yeah, so it will require both capital potentially and revenue. We have discussed potentially CRI, but that isn't finalised yet as a potential sort of base. And again, depending on the model that we want to take forward, I think we will come back to where that location best is to serve the whole of the population, Chair, I think, rather than just as we've got it currently, a Vale. So we do probably have some opportunity, I think, to bring the timescale forward, but I'm keen really that we do learn so that we do get the right model going forward. So it may be, I think, after we've had the review from National, that we revisit the timescale and the opportunity that we've got to bring that work forward, because I share the same concern as you. I think the opportunity for us around this is probably within the Cardiff the Cardiff area. I don't know whether that answers your question, Chair.
Thanks, Chair. Can I just take a supplementary before other people come in? This is a really dull question, I think, but just bear with me. Why is it so taking? Why is it the type of model for urgent primary care so nuanced? Because speaking as a layperson, it just seems to me the idea is have some urgent primary care in the community to deliver closer to home and to take pressure off, UHW. Why is that then so complicated? The model, I don't mean the actual mechanics of putting it in place and building the thing, but why is that so complicated? And you're saying we need to look at this model and that model but it seems to me that the idea, the concept is quite straightforward, isn't it? Is it, or am I just being stupid here?
Yeah, no, not at all. I mean, I think it's a fair question. I suppose when I talk about model, it's about how we provide it. So do we provide it across clusters by one cluster, etc.? Because we have to, the complication, I suppose, is around the workforce and using the limited resource we've got in the best possible way. So just to give you a flavour, I mean, we invested 1.1 million in workforce for the Vale Centre. So again, it's about how we use the GPs or the nurses, etc., the MDT, sort of the workforce to serve that population. So I suppose for us that's, given that we know we've got workforce constraints, that's the bit that we're working through about how we can best utilise the workforce that we think that we've got and we can recruit to. Does that make sense? And then the location bit is the sort of the second sort of part, really.
No, I get that, but surely, I mean, just to be devil's advocate here, surely you could agonise over things like that forever. Basically, there comes a point where you just got to say, just got to make it happen, So what do you say to that?
Yeah. No, I agree. And I think that point will be after we get the national review, because other people are doing it slightly differently to us. After we get the national review, we've already got, we know how the Vale is working. That point will come then. We'll have the information that we need to inform that model for Cardiff and how we take that forward. So I think that point for me will come as long as we can get the national review. I think will come in August, if that makes sense.
Right, this August.
Yes, this August. Oh yes, it's not next. It's not next year. Yeah. This August.
Okay, well, I'm putting a date in my diary, Caroline. Okay, right. Okay. Sorry to.
No, that's okay.
Yeah, grill there. Any other questions of that? No, thanks. Okay, well, do you want to move on to planned care then? Right.
Yeah, absolutely. So I'm going to bring in Hannah Evans, is going to take us through planned care. Hannah, do you want me to put the slides up and drive?
Yes, if you've got it open, Caroline, that'd be great.
I have, yeah. Give me a second. There we go.
So whilst the slides are coming up, there's obviously a lot of information both in the performance report, which is obviously the same format we've been using, and there would have been some in the flash reports as well that Marie talked to earlier. So if we go on to the next slide, Caroline, just start a bit like we did with urgent emergency care from a strategic perspective. So there's 6 goals for urgent emergency care, but there's 5 goals for planned care, so which at a high level set out the expectations really around and give some framing to how we improve planned care delivery going forward. And then the document in the middle, which is probably where the focus should be, drills into that in a bit more detail. So was issued afterwards. So in April, it's basically it's the recovery plan that is the short title, but you'll see the long title there. That sets out against 7 sort of high impact areas, some expectations. So those areas are outpatients. Rapid access to diagnostics is the second one. Third one's around cancer. The fourth is about a fair and equitable approach to how we prioritise patients waiting. And the fifth is around addressing long waits. And the sixth is about building sustainable capacity, elective capacity. And the seventh is about how we communicate with and support patients who are waiting. So that's the framing at a high level within that April document. But when you translate then into the actual measurable targets, it becomes quite clear really where the focus is and where it feels to be is very much in the long waiting space. So that's the only place really where there are measures. And I think I just wanted to draw the committee members' attention to as well the timescales. So some key targets in there, or ambitions as they're framed, that are replicated, as Caroline referred to the new outcomes framework earlier, but you'll see they've got differing timescales. So the ones closest to us is that first one around nobody waiting over 52 weeks for their first outpatient appointment by the end of the year. So that's December, not the end of the financial year. And the next one then is around not waiting 2 years for anything. So that's having had outpatients and treatment. So they're the 2 key delivery ambitions for this year. And we'll come on to talk about, if we go on to the next slide, please, Caroline, about how we're responding to that in Cardiff and Vale. So I'm sure we've sort of seen some of these slides before, but just to give the context against that national direction of what our challenge is. So on the left-hand side of that slide, the small chart, you'll see how our total waiting list has grown. Pre-COVID, around 80,000 patients, up to now we're about 125,000 patients waiting on the waiting list at all stages. We're doing some work, so there's this figure needs to be refined, but at the moment we think that equates to around 95,000 people. So it's not necessarily 125,000 members of the population. Some are waiting for multiple things. So we are going to have to do some work just to sense check that and check there's no duplicates. But that gives sort of the scale of focus on the sort of the scale of where we are. And the other thing I just wanted to draw attention to, which is really important in understanding some of the challenges of delivering against these, is the shape of our waiting list. Pre-COVID, waiting lists, when we talk about 36 and 26 weeks, had short tails, but the waiting list sort of came down gradually, and maybe a tail would sort of eke out a little bit. So smaller numbers at the end of a tail. So the challenge is in hitting these targets, but then is maintaining as well. So that graph there at the top right, that first arrow you see, that's the 52-week mark. So all patients to the left of that arrow are waiting under 52 weeks, as at the date this was run in May, and everything to the right then is over 52 weeks. So it's that whole block of patients needing to be seen. This is the whole RTT, but the shape is the same at the other level. So you can see there are bumps in it. That bump just over the 2-year mark is where we stopped doing activity. You know, when COVID kicked in, you know, it's just over 2 years. That middle arrow there is the 2-year, 104-week mark, and the third arrow on the right is the 3-year mark. So you can clearly see the impact that stopping activity had and what it's done to the shape of the list. So we'll come on as well to see that, as I said, the challenge is in achieving the targets, but then maintaining them, because every week there's a wave. If you look at that 52-week, if we clear all that, we've got the blocks are getting bigger and bigger in the following week. So it's very different to how it was pre-COVID. So I just wanted to spend a bit of time helping us understand that. In terms of that first, the most immediate performance ambition then is the 52 weeks, no patient waiting for 52 weeks at the end of the year. As at the 3rd of July, this was just over 31,500 people for us. So quite significant numbers of people we would need to remove from the list. Now we say remove from the list because obviously the main way of doing that is by seeing them, but there are other ways as well in terms of validation or people asking to come off or you know, sorting out the data quality issues. So that's quite a significant number, and there's a huge spread, as you would probably anticipate, in terms of specialties. So that graph underneath then shows where the higher volume specialties are. So they are in ophthalmology, orthopedics, general surgery, ENT, dental urology, and then a bit of dermatology and rheumatology as well. So in that 31,500, most of that is weighted towards some of those specialties. We'll come on to talking a bit about where what that means in terms of delivery of the target, and similarly for the 104 weeks by the end of the financial year, that's just under 22,000 as at the end of July. So that will include and that's but potentially can be quite it's harder to plan for because there'll be outpatients in that space, and will they convert into diagnostics, and will they then convert into treatments, all of which still need to be seen within the 104 weeks. So just to give us an idea of the scale of that challenge. If we go on to the next slide then, Caroline, there's opportunity within that. So we didn't touch on it too much because we didn't spend too much time talking about the performance report, but where we are at the moment, we are at just over 100% in our outpatient activity. And last week we touched 99% of our treatment, our inpatient and day case activity, which was our ambition by the end of the first quarter, with the intention then to grow it. We can see some examples of some of the charts we use to track that cohort. I've been using the word cohort a lot. Maybe I should just quickly explain, and apologies if it's obvious, but it doesn't, when I'm quoting these numbers here, it doesn't mean the patients that are as at today waiting for 52 weeks. It means all those patients in the bucket that will have waited for 52 weeks by the end of December. So some of them will be at 45 weeks today, but all of them will need to have been seen to achieve that target by the end of December. So we talk a lot about the cohort because we know what that is for 52 weeks because they're on our lists already. You can see as well some of where we are from a diagnostics perspective. That was a key delivery ambition. We were in a really good place pre-COVID. Then we're in a real challenging position, made some significant improvements, had a bit of a blip because of two particular modality areas, but have plans in place, and you can see the impact of those. So I just wanted to briefly touch on where we are in terms of performance, recognising, as I said, a lot of that's in the performance report. But I guess more importantly, where are the opportunities then in us improving our position? Yes, to deliver the targets and ambitions, but also to improve access for our population, which is obviously our key driver. So in terms of opportunities in this space, there's obviously we've had investment through the planned care monies. Our
22.6 million was our share of that. We are deploying across a number of areas, and it's really important that we make sure that we're getting best value from that, which we continue to do and sort of scrutinise on a monthly basis. But particularly in terms of planned care activity and capacity, as a very live conversation with us and with Welsh Government and delivery unit colleagues around some of these opportunities. So for validation, for example, is that number I quoted real, or are there opportunities around validation? We've actually made very good progress on validating. So we have validated down to 30 weeks. So that took 22% off the number. So the number that we're looking at, unfortunately, it's great that we've done the validation, but it's being validated. It's a post-validation number. Now, that's not to say there won't be ongoing gains from that administrative validation, but I think where we now need to probably look at, and there's parallel conversation now going on around some of these opportunities, is around where can we do some more clinical validation of particularly those outpatient lists, recognising the treatment lists are being reviewed very frequently. There's also some opportunities in what I guess we'd probably call sort of old-fashioned or basic waiting list management and sort of resource utilisation. So about our treating in turn, are we, once we've dealt with our urgent cases, treating then in turn from the back of the list all those patients in that cohort? Now it's very it should be obvious, yes, of course we are, but there are subspecialties, so there are some nuances within that. So get quite a lot of information presented to us nationally, challenging us on that. We do interrogate our information, and from an outpatient perspective, we're quite assured that we are treating in turn, but there will be some, as I said, nuances. For example, paediatric cases, paediatrics will be waiting less. They may be routine, so it will look like they've been treated ahead of adults who are routine, and you can translate that sort of position for a number of subspecialties. But there's definitely stuff we need to keep on top of to make sure we're doing that. And then there is something really, I think, where our biggest gains will be is around how we're using the resources we've got in terms of booking into clinics, the utilisations of the clinics, reviewing the templates based on some of the work we'll have done in the transformation space around SOS pathways and doing things different around follow-ups. Have we gone back and therefore reviewed the templates to see how they may need to change? And DNAs is definitely an opportunity for us. Our DNA rate for new patients is too high at the moment. It's higher than it was pre-COVID. So it's definitely something we need to drill into and understand, as well as making sure, we've talked about Barry a few times today, but we're exploring all opportunities in all of our estates. So there's live discussions at the moment about taking some orthopaedic activity into Barry Hospital to help address some of the backlogs in some of their subspecialty areas. We do have some constraints though in delivering. Obviously, we got the workforce challenges we'll be well aware of in terms of availability of staff, willingness of staff to work extra, our ability to recruit, and also some of the estate challenges that we've talked about. Some of our key jigsaw pieces of our site master plan, we call it, in terms of repatriating services and moving services, they are key enablers to liberating more space for some of this planned care work. So we are working with capital colleagues at pace to try to get some of those over the line. Okay, Caroline, next slide, if that's okay. So what that means in terms of what we're offering back, and you'll have seen this through our IMTP, this table summarises what our delivery ambitions are that reflect the ministerial priorities and that performance framework, outcomes framework that was referred to, but also some of our own measures that are important to us. For example, making sure that we continue to keep on top of the urgent cases, which is important clinically, for example. So we've got some of our own measures within this framework. I guess the one I just wanted to draw us back to that we did iterate as part of the IMTP update that you'll have received recently is that one about the 52-week waiters, based on the numbers that I've just explained to you, and based on our ability and our assessment of being able to see all those patients within that time. We've been unable to commit to doing that through our plan. But what we have done through going back and having a look in more detail is, out of the 35 specialties that are reflected in that cohort, we are confident that we can deliver that delivery ambition in 25 of those specialty areas, so 25 out of the 35. Which leaves some of those high volume, those 10 specialties I referred to earlier, and you saw on that chart, in those high volume areas, us developing improvement plans, so improving the position, but realistically not being able to deliver on that metric. And then recognising that, so at the end of December, there'll be a 52-week cohort, and then the 1st of January there'll be a new bucket of patients being added to that. So it'll be about maintaining in those 25 areas that we will deliver in by the end of the year, and continuing to improve the position for some of those higher volume specialties. So that's something I just particularly want to draw attention. It's very live in all our conversations internally in operations, and I'll talk in a moment about where and how we're doing that, but it's also very live in our conversations nationally as well. So if we go on to the next slide then, Caroline. So this next slide is a bit of an overview of how we're going to do some of this stuff. Hopefully many of the areas are familiar to you. So as you would expect, we're taking a twin track approach really in this planned care space, around making sure we're sort of grinding out, really, if you want a better expression, some of the operational improvements and processes we need to tighten up on to be able to enable us to increase activity and capacity, whilst also still keeping a focus on the transformational work that will help us think about the patients that are added today will become our 52-week cohort in a week's time. So how in a year's time. So how are we doing that transformational work to change the shape of that waiting list that we saw earlier in a sustainable way? So from an outpatient's perspective, it's a good, well-established programme of work we've got now that we do keep challenging and testing. We've got some new clinical leadership in there now, as other people have moved on to other roles, which has been great and real, injected some real energy and challenge into some of the areas. So really looking at health management, health pathways as a way to get right up front and upstream on that demand, linking in with the diagnostics piece about how can we get access to diagnostics earlier in the pathway, which will then impact and affect the patients that are coming through to actually require that face-to-face or indeed that virtual clinic. And we're using our interface GPs that we've invested in quite heavily to do this work, both to develop the pathways, but then to screen the referrals that are coming in as well, and screen them in line with the pathways, but also provide that communication bit back to GPs as well. So it's really whole system in that respect. Maximising use of digital, which is great in some areas, but we've just got to do some work just to assure ourselves we're maximising it in all specialties that are amenable to it. And the diagnostics, we're still, as I said, as well as linking in with the pathways, we continue to look at models regionally where we can share innovation and learning, so that we are sort of turning the dial in terms of the sorts of cases that actually need to consume theatre and treatment room time. So some really exciting work in that area. And from an elective treatments perspective, we've just completed a theatre improvement programme, a piece of work with some external support, and real positive changes, quantifiable changes you can see because of that work that the teams are committed to now embedding and making sure we get those sustainable improvements in all areas. And then we've got some specific specialty specific plans, orthopedics, as you would imagine, based on some of those challenges, using the GIRF, so that's the Get It Right First Time intervention that we've had in orthopedics and is now rolling out to gynecology and general surgery, real clinical engagement on doing things differently, and a real willingness to engage in some of the regional and national work as well. And eye care, our whole care eye care system plan is integral to that as well. So in the last column, in terms of the cross-cutting, remembering that we have that site master plan as a key enabler. I touched on it's really moving fracture clinic, the opportunity in Barry. There's a number of jigsaw pieces that will, as I said, lever us some additional opportunities. Through all of this, though, we are continuing to communicate and support patients. We have launched a website. We are going to do some comms to push the website. We paused on the comms to push the website just as the IPC guidance changed, because some of the stuff went out of date, because we very quickly modified capacity and modified service delivery to respond to the new IPC. But you'll see that coming through our spring newsletter, and we'll use that as an opportunity to push the website, which will direct stakeholders and patients to information about services and waiting times and how to keep well, etc. And we've got some good work going on in a number of specialties with, for example, the British Red Cross supporting people waiting in orthopaedics, and our colleagues, the rehab programme that's doing some prepare well work and the prehab to rehab work stream. So we are, whilst in our conversations nationally, the focus is very much on some of the long waits, we are continuing to explore all the opportunities that national plan had in order to improve the service we're providing. So the last slide then is just a very quick overview of how we're doing that assurance. So internally, we've generated new reports to make sure we're keeping on top of this activity. As I said, referred to earlier, there's a parallel meeting at the moment that's doing that weekly sort of rhythm of check-in and getting assurance that we're on top of some of those opportunities I mentioned earlier. And then we have the formal reporting through the one operational plan group that Caroline referred to earlier, and the exec review processes that have been re-established, and obviously through to here and board. And then external, I guess this is just to give colleagues a flavour of some of the scrutiny that's happening with colleagues. There are weekly reports, weekly meetings, monthly meetings, as well as some of the more established performance arrangements that we have with government. So the JET, for example, and our quarterly IQPD meetings. So it's very live, and there's constant communication around some of these challenges and opportunities. So that's all I was going to say. Appreciate it's a lot of information. I think the slides are going out by Nathan to share, and be happy to take any questions. Or Caroline, if you wanted to add anything, if I missed anything.
Nothing to add.
Okay, I'm conscious we've been going a long time, so I want to say let's take some questions, but I'd like to kind of take a break in 5 minutes for 5 or 6 minutes. So anyway, but Gary, yes, you're first off the blocks.
Yeah, thank you, Chair. And Hannah, thank you very much for the presentation. I mean, it was very interesting. It's actually quite an eye-opener. I mean, your analysis makes it very clear how complex and dynamic this this issue of waiting lists is. I've got a couple of comments and a question. I mean, I think that, you know, the workforce availability is clearly a central part of the issue, and I appreciate that there are so many unknowns in terms of recruitment, retention, but also further outbreaks of COVID and flu and goodness knows what else. So I really just wanted to confirm that I understood correctly that your prediction or estimation at this point is that reaching that December 22 target of no one waiting a year is not going to be achievable in all clinical disciplines, but in 25 of the 35 clinical areas. Is that the right Have I heard that correctly?
That's correct.
Then the second thing I wanted to confirm is that your estimation is that the residual patients who aren't cleared by December 22 will be in those high volume clinical areas, the ones that we saw in your graph, the ones contributing most to the 31,000 number. So if we can't sort that by December 22, the plans need to be in place to reduce it as quickly as possible after December 22. I mean, we can't, continue to have, 21,000 or whatever it is on that waiting for a year. So what is the if you like, the longer term plan beyond December 22, and what is your best estimate for reaching the zero number?
So I guess the first part is all the stuff you said in terms of checking understanding is right, Gary. That's the position we're in. In terms of those high volume specialty areas, we have put some challenge based on the opportunities we've identified back into those services. They have come, their improvement plans are being gone over as we speak in our performance meeting. So I wouldn't be able, it would be wrong of me to say to you now when, because we need to do some test and challenge on those. So we are committed to improving that cohort and bringing down the length of wait as well. So there's a number of ways to have a look at this in terms of the tail. We're committed to bringing down that tail, but same sorts of conversations we've had around mental health. Let's make sure we bring the tail down, the average weight down, as well as addressing the volumes. But I would just to flag as well, this cohort we talk about a lot is a cohort for December. And so whilst we will get that down and we will all be able to see what that looks like in December, hopefully tick that we've delivered zero in those 25 areas and see the improvement in those other areas and see the tail come down. 1st of January, the number will change. The number will go back up because there will be patients in January that will flip into that place. So I just wanted to sort of put, I know it's sort of maybe stating the obvious, but I just wanted to make sure that we understand that number will then will be slightly different when we look at this in January, because it will have a new cohort of patients that would breach that in January. So I think it's probably best to commit to bringing you back when we've had that assured work has been tested and scrutinised with those high volume areas, to bring back some of that detail so you can clearly see what that ambition around improvement is and when we'll be in a sustainable place. Because I want to point out as well that maintaining the zero in those 25 post December will be focused on it, but it's not we've done it, let's move on and get it down to 36 weeks. Because of that shape of that list, maintaining the 52-week position is going to require effort as well in some of those other areas.
Yeah, so, and of course December is just a target date, but there will be many other points on the timeline. So perhaps at the next meeting of this committee, we could get an update just to get a sense of where there is some traction. And if I may, Chair, just one very quick observation. I know that in some clinical specialities, cardiothoracics notably, there are concerns that our in-hospital stay times exceed the UK average. And I wonder, and I didn't see it explicitly within the last slide that you put up, but I wonder if hospital stay times may be an issue that we need to scrutinise in order to free up capacity, in order to admit more people off the waiting list, as it were.
Yeah, well, they'll bring that in. That's a good point. It wasn't explicit on the slides. We've got some good evidence around the length of stay in our protected green zones, as were, but it's about how we can make sure we've got that learning in all of our areas that maybe are not in the green zone. So yeah, we can bring that in.
Okay, thanks very much, Anna.
Okay, Sarah. You're on mute, Sarah, I think.
Sorry.
Yeah.
I just wonder when you bring that back, Hannah, whether you can also give us an indication of the risk, you know, and not just the time, but the balance of clinical risk for patients, and how that's being brought into play, because obviously then there's the interrelationship with all the other services that might need to come in and deal with the consequence of that risk. So
yeah, I think when we alluded to before about we've done lots of clerical administrative validation, we need to get into see what we can do in the clinical space, and that will bring some of that in terms of a bit. It's easier when we've got a treatment waiting list to look at the balance of risk. We've been using the RCS categorisation. They're patients that have been seen by clinicians in secondary care who are listing them. Outpatients is more challenging because, with the exception of sort of ophthalmology, and it's routine and urgent. It's quite homogenous, really, and they haven't been seen and assessed. So that is something we need to look at. And we're also working with in some specific areas. So some of the work we're doing on supporting patients, for example, how can we use information, potentially important information, whether that be clinical or social, actually. So the British Red Cross are out now with patients waiting for joint surgery. The clinical teams are keen to get some feedback on the situation of some of those patients that will help them understand and give them more up to date and maybe a bit of a more richer understanding. So we'll feed that in. We'll feed that in as well. But happy to do that, Sarah.
Okay, Jan.
Thanks, Chair. And thanks, Anna. Great presentation, and obviously a lot of work going on to really understand the dynamics of those figures, as Gary pointed out. And I'd like to just pick up on something Gary said, if I may. The 10 disciplines that we don't feel confident about achieving the 52-week waiting list by the end of December. Do we have a feel yet for what percentage of those particular specialty lists we will achieve? I've been challenged, for instance, with a suggestion that we're giving up before we start because the size of the list is so big, which I've resisted, obviously. But it would be good to have an indication of what we feel we can achieve in those 10 disciplines by the year end as well, please. If you haven't got the information today, Hannah, then perhaps at the next S&D committee, that would be helpful. And the other question really is patient safety and well-being? How are we connecting with and keeping those patients on these lists up to date with where they are and any progress that we might be able to make for them, please? Thank you.
So on the first point, Jan, I think, yeah, those improvement plans we've challenged those specialties with. So we will have an improvement trajectory. We do expect them to get better and not sort of give up, and we are in a way wrapping around even more support. Our assessment is that many of those 25 areas, if they do some of these basics and take a number of actions, then they should be able to deliver. Whereas, for example, orthopedics, it is going to take more, hence supporting them with the exploration of Barry as an opportunity to create capacity. So in a way, we're disproportionately putting support around some of those areas to make sure those improvement plans are challenging and are ambitious. And okay, they may not be able to meet the ministerial ambition, but they will definitely improve the position, and we can give some clarity on what we expect that to be. So we'll share that when we've assured ourselves those plans are as stretching as they can be. And on the second point, it is a little bit about what I was referring to earlier, but I do think there is probably more we can do. But I talked about the generation of the website that's got have information at service. It does have information at service level. You can click on orthopedics and it will tell you how orthopedics is running. It will redirect. It will talk about the British Red Cross support, the Prepare Well that the OTs provide. We'll also direct to the Keeping Well, the website that was developed So sort of a package of measures around communication and then direct support to some areas. Some specialties are supporting through using their clinical nurse specialists to keep in touch with patients to make sure we're aware of what's happening with conditions. So different specialties have different, slightly different approaches, but at a all system level, it's through some of our communication mechanisms. So I think there may be something we can do in pushing and promoting the existence of that to our stakeholders and directly maybe to patients as well.
If I may, Chair, I think that's really important, Hannah, that we do keep in touch with these patients. I know we're in a digital age, but not all patients will be digitally alert and aware. So we need to think about how we make sure we give them as much reassurance as we possibly can whilst they're waiting for their specialty treatment. Thank you, Chair.
I agree. Thank you.
Thank you. Okay. Well, thanks, Hannah, for that. Right. I propose we take a break till say 11:05, and then it'll be Rachel up on health and safety culture plan. Okay. Thanks, everybody. See you in a minute. Okay. I think most people should be coming back now. So first of all, I'd like to thank Caroline and Hannah for those presentations. I think we need to formally note our thanks and record that we noted and discussed those presentations. Thank you. And now on to Rachel with Health and Safety Culture Plan.
Yeah, I'm just going to introduce it today, Chair, and then introduce you to Rob Warren, who's just joined us. He's the head of health and safety, so leading this. I suppose a little bit of background. Prior to Len, our previous CEO, and my predecessor commissioned a piece of work around health and safety. They commissioned a review from an external body to come in and really look at our structures, and also link in with Nikki Foreman, to look at the structures, but to dig a little bit deeper around our health and safety ethos and culture in the health board. So there were 6 themes that came from that, which Rob will go into detail around today. But really for me, it was about a 3-year plan linked into our people and culture plan. Our health and safety is a bit of a brand to ensure it's about keeping our people safe ultimately. So whether that's regarding our human resources side or whether it's regarding our health and safety side. So this plan was devised in a very similar way, co-produced with the health and safety team, but with a collaboration for all our colleagues within the health board. So Rob is going to present a few slides today and to go into a little bit more detail. So thanks, Rob, for being here.
Okay, thank you. If I just share my screen. Okay, can you all see that?
Yes, we can, Rob. Yeah.
Okay. Morning, everybody. Thank you very much for that, Rachel. Okay. So the health and safety culture plan, as Rachel just alluded to, this is a document that sets the scene for the next 3 years and beyond. Since coming into the health board, I think it's fair to say that we take too much of a back seat and rely on reactive measures towards health and safety rather than proactive. And the intention is with this document to make us a more leading organisation when it comes to health and safety. It's going to introduce fundamental systems and processes that will embed health and safety into the operations of the UHB, and it'll also align us to the best industry practice that's out there. And in terms of culture, there is no shortcut. When changing culture, we just can't jump 3 years down the line. This is a path that we have to go to. It's also difficult for one element, one site, one department to be on this journey alone. This is a full UHB-wide document, and it's there for us all to follow. As I say, it's difficult for one team or one department to be on this on their own. I think it's also fair to say, in terms of health and safety, it's one of the most important documents that we've compiled at Cardiff and Vale. It really is that important. So for the plan itself, there was a number of inputs. Predominantly, we had the RLB review that was conducted last year that Rachel mentioned, and that's very much formed the backbone of it. That document, the report, is not stuck on a shelf gathering dust. It is being used and it's being utilised into this culture plan. We also had a department workshop last year, which was very fruitful, and it allowed the department. There's a lot of expertise, knowledge, experience within this department, and it was crucial that we tapped into that and put those ideas into this plan as well. We've also listened. There's outputs from department meetings around the UHB, which we've also incorporated. And hopefully, I've also added a little bit of external knowledge and put that into there as well. So all those things have been inputted, and hopefully, the output is a very usable document that's going to help drive the culture over the next 3-year period. So the plan itself, it's got 6 strategic themes, and there's a departmental lead for each theme there. So at the moment, with the input that these people had at the sort of planning stage for this document, they are now leading on this from a department perspective. It's not being led by me at all internally in our own department. The leads really have stepped up to the plate and they're pushing this. The actual document, it details the aims and objectives and the collaboration that's required to bring about the change throughout the UHB. If you've had the opportunity to read it, hopefully you'll see what I'm talking about there. The whole document is also underpinned by an objectives document, and this is the part that really gets me out of bed in the morning. This is the stuff that details how we're going to achieve, what we're going to implement, how we're going to do it, and by when. So it contains 111 actions, all in all. So there's a considerable amount of work for us to get through over the next 3 years. It's going to need the buy-in from the clinical and service boards without question. We can't do it on our own. But these targets are and actions are specific, they're measurable, achievable, they're relevant, and most importantly, they are time-bound as well. And finally, this is around future-proofing and the tracking of the external review actions. Again, as I said earlier, a lot of these actions have been incorporated into this plan, and it's important that we are transparent as a department and we are seen to be implementing these actions and pushing them through. So we had an audit conducted in March this year by NWSSP. They've come back with substantial assurance, which is quite pleasing, largely because of these actions have been incorporated into this culture plan. So it's all well and good having substantial assurance now, but for my mind, what I need to be sort of held to account on is where are we at in 3 years' time? Are we still able to provide that substantial assurance? And we can only do that with the buy-in from the clinical service boards. We need their help in incorporating the actions from here to enable us to maintain this level of assurance in 3 years' time. And finally, this culture plan progress will be taken to the Health and Safety Committee every quarter, and a progress assurance report will be submitted into that forum so they can see exactly where we're at any moment in time then. So that's it for me. I didn't want to elaborate too much with the slides. I realise everybody's very busy, but obviously I'm more than happy now to take questions on this.
I think you're on mute, Michael.
Sorry, schoolboy error. So Rian, I think, just in first, and then Sean. Sorry, Sarah.
Yeah, Michael. Thank you very much, Rob. Sorry for being off camera. I'm having a whale of a journey with Teams this morning. So apologies for not being visible. But yeah, thank you for taking us through that. You make a very salient point about being proactive about this stuff rather than reacting, which, yeah, a very sound point. I just wanted to expand the question a little bit and talk about our subcontractors, contractors, who come in to the health board to perform work on our behalf. It's going to be a big job implementing this culture, this plan within the organisation. But what about to third parties? You know, outside the organisation. What's the plan, I guess, for ensuring that those principles are upheld?
Yeah. So health and safety starts at board level, and it starts with the health and safety policy. We've now got a health and safety policy statement of intent, which we didn't previously have. We need one, and we now have one. So it starts with that. That needs to be rolled out to all the contracting companies as part of the contractor management scheme. From there, we've also made some slight structural changes in how we manage contractors since I've come here. And where the higher risk work is involved, KEF will now be controlling more of that, whereas previously it sat outside. It's also in our health and safety culture plan. There's an element on contractor management, and we are looking at how we are going to improve that for the clinical boards. A lot of these people, you can't be ignorant to health and safety. Standing up in a court of law and saying, I didn't realise, obviously is no defence. So it's about cascading this out. We've done it once previously a few years ago. That's going to be rolled back out again in a slightly different guise. The clinical boards will know, they will understand what their requirements are under contractor management. So that's the day-to-day work. And as I say, the higher risk work will be controlled by KEF, and they have a more robust mechanism to control this work.
Okay, so if I understand properly, it's a combination of binding suppliers contractually in terms of expected levels, but also
Yes.
culturally making sure everybody knows what is acceptable and what isn't.
Yes, so yeah. I'm also working on a RACI matrix, which is responsible, accountable. Yeah, and in there I've got a specific element on responsibilities and contractor management in line with our new management system that I'm incorporating. There's an element on contractor control, contractor management, and in there I'm working on the RACI. I'm in the process of setting up a meeting with procurement, because contractor control ultimately starts with procurement when they go out to tender. And I'm just firming up. KEF know what their responsibilities are. Health and Safety Department know what their responsibilities are. The clinical board they need to know, and also procurement. And I'm in the process of firming up the RACI now at this moment in time.
That's great. Thanks, Rob. If I may, if you're willing, I may follow up with you on where that progresses, just out of interest.
Absolutely. Yeah.
Great. Yeah. Thank you.
Okay, Sarah.
Yeah, this is a really impressive plan. It's very detailed, and as you say, it's kind of well thought through. So thank you very much. You sort of refer in the paper to DATIX and the patient safety aspects of health and safety. And I guess the other interdependencies are the ability of our teams, like the facilities teams, to act on some of the concerns and the areas for action. So I'd like to get a sense from you of how you're working with facilities and also with Jason and his team. Congratulations, Jason. It's all yours now. Deep joy. So just and you know, where you see that and where you see the sort of the risks and also the opportunities around that.
Yeah, so risk is a funny old thing. We should embrace it. And that might sound strange coming from a head of health and safety. It can lead you on to improvement. It can lead you to make better decisions going forward. So there's a whole piece around risk and why, as I say, we should almost embrace it to a certain extent. Obviously, intolerable risk is another matter again. So I've been working closely with facilities, with capital estates and facilities since I've been here, building relationships within that team. I've had a certain amount of reassurance of the work that they do. It's done to a good standard, a high standard. They've got a heck of a task, as I'm sure we all appreciate on this call. So I've been working with them. It's about assessing risk as well. So and prioritising through risk assessment. So that's a piece again that is in the culture plan to set up a proper, a more detailed risk assessment process than we've got now, or to improve it then, if you like. Everything in there is about continual improvement. So that's a piece there for facilities, assessing the risk, getting it properly done. But it's also a team sport, so it's not just about facilities. It might need the clinical staff to get involved in that risk assessment process as well. It's around getting the right team whenever you're assessing risk. With regards to patient safety, I will be honest with you, they've also got their own patient safety team who I've had small meetings with, but I've now set up, or we've set up between us, myself and patient safety, more structured meetings going forward, where I will have more involvement with them, because that partnership working is paramount. Without that, we're not going to go anywhere.
Thank you. Okay, Jason, did you want to make a comment on patient safety, or was it a standalone question?
It was a comment, and I think Rob touched upon it. So not that I've had time yet in the first week to have a conversation with Rob, but I know Rachel and I have discussed about how we bring health and safety together with patient safety and quality, and how we look to move forward in that sort of joint arena going forward. So we can brief you at a later date.
Yeah, if I may, Chair, that's really important in the culture change piece as well. So it'd be good to see that reflected a little bit in the culture aspects of this. Sorry. Yeah, sorry. That's so yes. Okay, I'm going now.
I think Michael's frozen, so should we go to Gary's question?
Yes, thanks, Nikki, and Rob. Thank you for introducing this, and you know, I think it's a very sensible, readable, and a focused document. So well done. I'm sure things in the action plan will be refined as you go along. I mean, what struck me is that earlier in the meeting, and probably in every meeting of S&D that I've attended, we've had information on mandatory training compliance, and we know that it's slipped very, very low in some areas now. So I think that a couple of your initiatives, perhaps, you know, protected time for mandatory training, and a risk-based approach, you know, those who are at most benefit should be the ones where you have 100% compliance. I think that's very sensible. One of the comments I'd like to make about the action plan is that some of the outcomes or measured achievements refer to improvement in a figure, and I think it might be helpful for some, not all of them, to actually state a figure that you anticipate as a target. If it is 100%, then you know that should be stated. So it's really just about making the measures truly measurable where it's possible.
You know, that's a valid point. Thanks for that, and I'll certainly take it away and have a look at that.
Okay, thanks. Sorry, I kind of dropped off then. I don't know why that was, but I hope I'm back in full effect here. Thanks. Can I just I have to bring this to an end in a minute, but Rachel can sum up in a second. But the final point you had on your points of action was the Health and Safety Committee, and I also sit on that. And I think this is an interesting point about the relationship between this committee and the Health and Safety Committee. So how this is so it's got a strategic element to it, which we should be obviously seized of, but it's got a more operational element to it, which the Health and Safety Committee should be more seized of. So how do we join those two things up? And I was thinking, you know, almost in a way, is there a possibility of one day almost having like a combined strategy and delivery committee and Health and Safety Committee once a year or something, where maybe for an hour both committees discuss this common topic or something like that. So I just yeah, that, because the danger is that we all the committees either duplicate work or go off in their own separate directions. So how do we square that circle? I mean, and maybe the answer lies with Nikki as much as anybody else, or Jan. I don't know, but I just throw that out there. Robert, what do you take on that?
I was going to conclude on that actually, Michael, but I think Jan's just coming in. So
okay, well, yeah, well, okay, well, Jan, you go. You go first. Yeah.
Thanks, Chair. I'm not sure there's a queue now to come in, and Nikki's probably best placed. I think, Michael, is a really good suggestion, and I'm so pleased to see health and safety and the word culture featuring so prominently, and the plan coming to S&D committee today. It is going to form part of the review I mentioned to independent members last week, Michael, how we shape these committees going forward. As we're refreshing our strategy, it's really important we take a look at our committee structures as well. And I will engage with independent members, obviously, to get your views as to what the best format might be. And Suzanne, Nikki and I will be linking in perhaps initially just to get some framework or a loose framework, and then we'll negotiate and discuss as a group of IMs as well as to what's the best way to give assurance to the board in all of these matters. And we'll pick up health and safety most certainly, Michael, in that context.
Yes, thanks, Jan. Nikki?
Yeah, just supporting really, Chair, what the Chairman has just said as well. Basically, I think it would require, as Jana said, we're doing this review of committees of the board, and I think alongside that it would require a sort of mapping out exercise of where there is crossover, because absolutely to make these meetings more effective and efficient, we don't want duplication. So we don't want the same document, which is happening at the moment, going to several places, the same document in the same context and being presented in several different places. So some people, somebody like me who sits on all these committees and goes to ME, see the document several times over. So that's not efficient and it's not effective. But I think this isn't the only area, health and safety, where there's that overlap. So I think it's a really good idea, and I think we can pick it up alongside, as the Chairman has said, that review of the committees of the board, this area and other areas that overlap with strategy and delivery, but also other areas of our committees. It's not just the overlap between the committees and strategy and delivery, there's other overlaps. So it's looking at it in probably a sort of matrix or something and mapping that all out, and that will feed into the overall review.
Thanks, yeah. Did you want to come back, Jan, or was that a legacy hand we have there?
It's definitely a legacy hand, Michael, which I will now withdraw.
So can I ask then Rachel just to sum up and the discussion, please?
Yeah, no, great. I think having taken over the lead from October as the exec lead, it was important for me to bring it, noting exactly what Jan and Nikki have just said. But today it was important to bring it here today around the culture part of it. So we could have just taken it to the Health and Safety Committee because they did approve and sort of assure it. But it was about that culture and that join up with our people and culture plan. So we're trying to reframe this agenda in a positive way, because like you say, sometimes people feel it's a mandatory and statutory requirements, and so it's about how we look after our people, hence why it's here today. But Jason and I, like he alluded to, are going to work really closely around bringing those two agendas together. So well done to Rob and the team, but thank you for today.
Thank you, Rachel. Yeah. Okay. Right. So Jan, is that your hand up again, or are you still, I don't know, was it my machine playing up? I don't know.
I think it's your machine this time, Michael. I can't
okay,
see any halo around my side.
Okay, well, apologise for that. Okay, so the committee has requested to note the findings of the plan and the objectives identified, and that, as I say, we and at the Health and Safety Committee will get regular updates. But as I say, we discussed that a way of feeding back into this committee as well, in a way that doesn't duplicate or replicate work, but satisfies us strategically. So I wanted to move on. We're a bit pushed for time, but I did ask Abby and Marie about a brief overview on policy and planning framework, because I think we have so much going on, and I've seen the slides, and they're very user friendly. I'd like to think. So I think if we can kind of go through this quickly, Marie, is that you speaking to that?
Yes, I am. But as you say, Michael, I think, you know, this is just background information that you just requested. You know, could we do something kind of a bit Janet and John that showed how everything sort of joined up? So I don't need to go through these, given that we're so pushed for time. I think, you know, as I say, it's just we've tried to break down the way that NHS Wales operates into bite-sized chunks at kind of governmental, policy, strategic, and then structural level, just to show who's responsible for producing what and how everything should fit together. And I think what this slide pack shows is that it isn't a nice, neat kind of wiring diagram. It is, in fact, an ever shape-shifting jigsaw. But it is where we are now. It's not when we've listed some of the you know, key stakeholders. It's not exhaustive, but if any colleagues would like me to expand on any of the areas of those slides or follow up with anything further, I'd be very happy to.
Thank you. I think that's helpful. I thought they were, yeah, I like Janet and John, so I thought they were very helpful. Thank you. Gary, comment?
Yeah, thank you, Michael. Marie, could you send the slides as a separate PowerPoint file, please, because it's difficult to disembed them, and it's so useful to have as a reference tool.
Absolutely, no problem.
Yeah, that's a very good point. Very good point, Gary. Yeah, thanks. But it's something we probably will return to in more detail going forward, because it's something I'm keen to keep an eye on how it all somehow fits together, because I find it confusing. Rian?
I just had to Google what Janet and John was, but okay, I'm back with you.
Too young, Rian, aren't you?
I just wanted to say, fantastic, really helpful, and we should think about putting them in the IM induction packs, and also for any so if we have new executive members that have come from outside the Welsh system, I think these would also be very helpful in their induction packs as well.
Yeah, good idea.
Thank you.
Okay, thanks. So thank you, Marie. We'll note the slides, and we can digest them at our leisure further. Right then, 2.6, childhood immunisation. Fiona.
Thank you, Michael. I've actually got two papers in. One has been put in for information and one for approval, but they've both got similar recommendations. I don't know if you want me to take both of them, but I'll cover childhood vaccination first. So I'm just going to summarise the paper, really. Vaccination, as we know, and we've seen through the COVID period, is one of the most effective healthcare interventions that we've got. What's clear, and what you'll see from the paper, that during the COVID period, our childhood vaccination that is mainly provided through primary care seems to have slipped in terms of rates. So we've got a declining overall rate for some vaccines, not for all, but for some, such as measles, mumps and rubella. Even though childhood vaccinations were kept as an essential service in primary care during the COVID period. So the paper just outlines some of the statistics, for example, and I think what you can see there is a clear pattern of inequity. So in some of our clusters, we have higher childhood vaccine uptake than others. If we compare, for example, City and South to Cardiff West, for example. So there's clearly something we need to do to tackle inequities with regards to immunisation. So the paper outlines a series of actions that I would plan to lead that is linked with clinical board delivery. So we've relooked at the governance of immunisation and vaccination. That's outlined in your paper. Most of this work is led by PCIC and Children and Women. It will be picked up through the performance route. And Caroline obviously links in an operational exec lead, and I link as an exec lead for immunisation. And I have a professional lead who supports that work too. And in the paper, it outlines the series of actions we will take. One of those is the support that partners, particularly our local authority partners, are willing to provide to wrap round support. So use of their community hubs, staff and workplaces encouraging and supporting uptake of vaccinations. So we'll be working on specific actions in amplifying prevention over the autumn. There's some new staff within the envelope of immunisation funding, so that a locality type approach can be taken across Cardiff and Vale. And we'll have a comprehensive communications campaign as well. And we've had some work done by an external agency on that regard, looking at the branding, etc. And we'll do some specific work with our ethnic minority communities. And it's clear, I think that's a really important part of vaccination programme rollout, and that was clear from the COVID vaccination programme. So I'm looking for you to note the content and to support the plan to increase uptake over this next rest of the year through till next March. Thanks, Chair.
Thank you. Yes, we'll take the flu one next at the second. But any questions arising on that paper by anybody? Is that Rian?
Yes, please. Sorry, just a really quick one, because I know we're pressed for time. Fiona, I'm so pleased to see us focusing on this. It's so important. I've got a question clarification, which sounds a bit facetious, but I promise you, it's me just trying to get my head around what the difference is between a operational immunisation board and the operational immunisation steering group that it's replacing. What does that mean in practice? Because they do sound quite similar.
Yeah, I think what we've done, Rian, in reviewing, so I reviewed all our vaccination approach and how we managed it. And traditionally and previously, we had a very granular operational group, sort of hit at the level of senior nurse and that very granular ops level. What we've done is lifted it up. This is a piece of work in shaping our future population health. It's a key priority, and that operations board will be led by the director of ops in both of those clinical boards. So I think we're lifting it up operationally to be led by those directors of ops. Does that answer your question?
Yeah, no, it does. So it will get by default more focus.
More focus, more attention, easier troubleshooting, I would say.
Great, lovely. Diolch, Fiona.
Thanks.
Okay, thanks. So we'll jump forward to item 4.2, so we get a double helping of Fiona. Yeah.
Thanks, Chair. So again, there's quite a lot of detail in this paper. Flu vaccination is really important and probably overshadowed, I think that's fair to say, in the COVID period and with the attention on COVID vaccine, and often with staff being diverted to work on COVID vaccine delivery, and arguably maybe to the detriment of flu vaccine. Interestingly, what we're seeing in the Southern Hemisphere, such as Australia, we usually look to the Southern Hemisphere to see how their winter plays out. Doesn't always follow through, but it often does. And Australia in particular is seeing quite a strong flu season. If you look at the graphs for the past 2 years, we haven't had very much flu circulating at all, probably because of all the other measures that are in place, but of course because of the vaccination programme as well. It looks like we may have quite a hard winter in that regard. And so this paper highlights the actions we plan to take and the reflections on the flu programme this winter. And I think what is clear, it's a mixed set of delivery. So you'll see general practice provides to some of the population. Community pharmacies have taken a bigger role with us, both on COVID vaccine and flu vaccine over this last winter. School nursing team, occupational health, UHB flu leads and flu champions, and the mass vaccination team. So it's a wide programme with many different people who deliver. You'll see again that our statistics are disappointing. It's reflected across Wales, but nevertheless, we've also got more to do comparatively to get our rates up, even to the all Wales average. But you'll see on the second page just the range of groups that we provide to. 6 months to 64 years at risk, for example, 65 and over, 50 to 64-year-olds. What's interesting is that England is slightly different. They haven't extended their flu programme to 50 to 64-year-olds, and they don't include secondary school-aged children, but we do in Wales, so there's a differential there. So you can see the statistics. You can also see that, again, there is an inequality pattern across Cardiff and Vale Glamorgan, and we'll be working really hard to change that over this winter. And you can see in the paper the plans that we have to improve uptake. One of the things the Welsh Government is doing this winter is that there will be a combined COVID and flu plan nationally, and we will be creating a combined COVID and flu plan accordingly. There'll be different elements in both, but that where possible, we'll join up action as well. I think you may have heard me say before that it's not possible just to administer all COVID and flu vaccines together because of the way vaccines are procured. So primary care procure their flu vaccine a year in advance of the year in which they're delivered. So it is something that Welsh Government is looking at to look at whether we can get added advantage in future years, but that won't happen this year. You can see the range of issues outlined in my exec director opinion. We think there's a bit of vaccine fatigue for any vaccine, so we have to work hard, I guess, to work with the public about its importance. And we will be trying, different methods like building on the Flying Start childcare setting to perhaps give some vaccines for the 2 to 3 year olds. So you've got a list of actions there of how we will plan. The aim is to put it also into that operational board, but they are just getting going, and we'll see how that goes in terms of that board taking it over. Currently, it's my consultant lead who's leading, working with occupational health and other colleagues around the articulation of those components of the combined plan. Happy to take questions, Chair. Thanks.
Thank you, Fiona. Any questions arising? Jan, I think, just in first.
Just broke the tape before Gary. It's not really a question, Chair. It's more observation on the importance of the work that Fiona has just brought to our attention, both in childhood immunisations and flu vaccine. I think it's really important that this committee continues to find a way of supporting Fiona to deliver this work and give assurance to the board that we move forward in both areas. So great stuff, Fiona. Thanks very much.
Thank you. Gary?
Yeah, thanks, Fiona. Just a quick question about co-delivery. I presume that means co-administration. I mean, two at once. There is a slight technical problem that I don't know if it has been ironed out, and that is that the eligibility criteria for COVID vaccine and flu vaccine may be different for a particular group of people, in which I now sit. That is the over 50s, but the under 65s. Or the over 60s and under 65s. And I wonder if the JCVI is moving towards a position, because I think the last time you spoke on this topic, you said that actually the situation was that COVID vaccine eligibility would be for the over 65s, but not those younger than that.
I mean, it is interesting around they're overlapping circles, the eligibility groups. And I guess eligibility pertains to technical analysis of who should be provided the vaccine. So there are sometimes some differences, and in part that just adds a complexity to delivery. But just to say that the JCVI are still deliberating on the 50s to 64s for COVID vaccine, as well as children aged over 5 up to 64 for the clinical at-risk group, or up to age 16, sorry, that's the bit that's missing for the clinical at-risk groups for COVID vaccines. So I understand that is with government, UK government. We just haven't seen the results of that deliberation, Gary, so we should have clarity on that relatively soon. But in any case, you've highlighted a complexity in delivery, and not all eligible groups are eligible for both in some instances.
Thanks.
Okay, thank you. Right, well, thank you, Fiona. We're asked to note and support, so we'll do that. So thank you very much, Fiona. Dipping back to 2.7, so I've got 2 items which are now Nikki's items. 2.7 board assurance framework, Nikki.
Thanks, Chair. So committee members will be aware that we bringing each strategy and delivery committee the board assurance risks that are relevant to this committee. So the three that are here today: workforce, leading sustainable cultural change, and capital assets. I mean, Rachel's already talked about workforce in quite a lot of detail, and we've also touched on culture change through the health and safety report that we've had. Capital assets has been updated prior to this meeting. It managed to catch the papers going out. The other two are actually still from the last board meeting. Because obviously the timing of these papers. But the only other thing I'd say, Chair, is workforce and capital assets are two of the highest risks on our BAF, scoring at 20. And then leading cultural change is a slightly lower scoring risk. Also attached within the report is just the details of what risks we're going to be reporting through this committee through the coming year. Rachel and Marie, I'm sure, are happy to. Rachel leads on two of those risks. Marie, who's here on behalf of Abby, will lead on the capital assets risk. If any members have got any questions, I'm sure they'll be happy to support or answer any queries on that. But other than that, Chair, happy to open it up for questions.
Yeah, Marie, comment?
It was just double checking in terms of capital assets, because obviously from a planning point of view, planning the development of our strategic estate sits with Abby, but in terms of ownership of KEF and capital, I think that sits with Catherine.
It does.
Yeah.
Abby holds this risk though, Marie, so she updates this risk.
That's fine. Just double checking. I didn't want to commit Abby something in her absence that I'd clobbered for.
Okay, thanks. Jan?
Thanks, Chair. It may be that we take this one offline, Nikki, really, but I'm just concerned about the lack of profile we've got on our BAF for digital capability, and whether we need to consider that as a separate issue. But probably is something that management exec need to talk about first of all, and then consider it in line with the other high areas of concern we have. But I am worried about digital capability going forward. Thanks, Chair.
Okay, thanks. Any other points arising? No. Okay. We'll ask to note the BAF, and so move on to item 3. No items for approval or ratification. That takes us then on to items 4, and that's Nikki again at corporate risk register.
Sorry, Chair, bit of a delay there on my admin control. So yes, same really. So these are the corporate risks from the corporate risk register that are brought to this committee, and they're risks rated over 20 and above. There's currently 7 held on the corporate risk register. The only thing I would say, looking at the details of these risks, I think we need to start challenging the clinical boards about being a little more dynamic on management of these risks. Some of them, the initial score is 20, and then after the controls are in place, they're still scored at 20, which would suggest that the controls aren't having an impact. But I'll pick that up with my team to sort of do a little bit more check and challenge around those risks. Members will be aware, we've been on a journey with our risk management processes, systems and structures, and I think we've got the structure in place now, but obviously making sure that people continue to remain engaged and risk management remains dynamic is an ongoing situation that we need to tackle as a team. The only other thing I would suggest as well is that we need to link in better with people like Marie. I mean, Marie's been through Q1 Imtp and detailed some of the big risks on there, and it's how we capture those and link those into our corporate risk registers and risk registers per se. Again, just to make sure it remains dynamic, because at the moment it's very much by clinical board and by corporate directorates, whereas it's making sure those project risks are also captured. So if they come to the top, boards and committees are cited on those risks. So I'll take that away. But as always, risk management is work in progress. There's always areas to improve, and we can do better. Thank you, Chair.
Okay, any questions arising? Yeah, Jan?
Apologies, Chair, for asking another question. It's a thought process rather than a question. This is technically a governance issue, managing risk. I understand that, but I'm just wondering if exec colleagues are aware if this topic is discussed in their performance reviews with clinical boards as part of their overall performance, how they're managing risk and how they're keeping up to speed with it. Thank you.
Carolyn wants to come in on that, yeah?
Yeah. In all reality, actually, we don't actually look at the risk registers, but looking at the risks on the risk register, we do discuss those specific items. So, for instance, I was just checking on the medicine and clinical board. Some of them around ambulance handover, workforce, etc. So the items are discussed, but not the risk register. So I think that's a fair challenge, Jan. I think probably we'll incorporate a review, and that might help Nikki as well in terms of that, a review of the high risks within the next performance reviews. So I'll take that away as an action to make sure that we do not just discuss the item on the risk register, but we actually discuss the risk register itself.
Thanks, yes. Well, Gary, I'll take Gary first, then Nikki can wrap up. Gary, yeah?
Yeah, thanks. It's just an observation for Nikki to check and confirm, but the date on which these risks were added, they all seem fairly plausible, except for haematology and immunology clinical environment, which has been on that register since 2010. If that's wrong, then it should be corrected. If it's right, then we should be very worried, because sustaining a risk for that period of time is, well, it doesn't show us in a good light.
Thanks, Gary. Yeah, Nikki.
Absolutely, Gary. I'll take that one back. I hadn't actually spotted that level of detail, but you're absolutely right. And it might be it goes back to what I was saying about making sure this remains dynamic, making sure that the actions that they put in place are dealt with and delivered, making sure that the controls are having an impact. I mean, that risk is very high scoring. Before controls are saying it's a 25. Anything I would say that's a 25, you should just stop the service. So my challenge to that area would be: is it really a 25 without those controls? After the controls, is it really a 20? If that's the case, what are you doing about it? Because it's been on the risk register for the last 12 years. You're absolutely right. If that is the true date and that is the true risk, it needs to be looked at. I'll pick that up with the relevant area and take that back. But yeah, really helpful spot. But it does go back to what I
consolation, Nikki. I've looked at this. I don't know how many times before in the past, and it's the first time I've noticed it today, but I think we do need to iron it out.
I think you're right, absolutely. And it goes back to what I say, is making sure that these documents remain dynamic and up to date, and then it's not just a tick box exercise, and it's making that risk management real within the organisation. So it's an ongoing challenge for us as a team and those people that are actually dealing with the risks. But thank you for highlighting that. Thank you, Chair.
Thanks, Nikki. I just wonder, Nikki, when we have the next agenda setting meeting next month, I guess, might be an idea to maybe make more time to discuss the risk register and its mechanics, its aim and purpose at the next meeting, because we kind of often do kind of go through it at some speed. So I just wonder, well, remind me to kind of float that idea at the next agenda setting, I think. Yes, okay.
Okay, happy to do that. We'll take that away as an action, Chair.
Yeah, thank you. Okay, right. AOB on the public meeting. Just something I wanted to say, I should have said at the very beginning, was welcome to Jason, who's here formally in his new post. Congratulations, Jason, and welcome to the committee. I'm happy to have many meetings ahead with your input and help and support. So thank you for that. But in contrast, it's the last one of one of our erstwhile members, Caroline. So Caroline, again, on behalf of the committee, I want to say thank you very much. You've always made a very helpful contribution in the presentations, and it's been in difficult, complicated areas. even you've made it so that even somebody like myself can understand what's going on, and I think that's so very many thanks from the committee for that, and the best of luck across the bridge. Okay, so let's we need to go into private meeting now. I don't think we have. Do we have to change any links or anything, or can we just go straight through into it? Just want to check. I'm assuming that means we can go straight through into it.
Michael,
yes, you can, Chair. We'll just stop the live recording.
Yeah.
And Michael, will you accept my apologies? I have to leave now, please.
Yes, thank you, Jan. Thanks for your contribution.
Good meeting. Thank you, everyone. Thank you.
Thanks.